Welcome to QuickMedTalk, your online destination for medical lectures. Let's talk about sinusitis. Definitions in sinusitis. And sinusitis. This is inflammation of all sinuses on one or both sides. Acute sinusitis. This is inflammation of the sinuses for less than 4 weeks. Subacute sinusitis. Progressive symptoms of sinus inflammation occurring over 4 to 12 weeks, which represents a transition from acute to chronic infection. Chronic sinusitis. Persistent symptoms of sinus inflammation for more than 12 weeks. Recurrent acute sinusitis. 4 or more separate episodes of acute sinusitis that occur within 1 year with at least 8 weeks of symptom resolution between episodes. Anatomy of the sinuses. The sinuses are hollow air-filled sacs lined by mucous membrane. There are 4 pairs of paranasal sinuses. The frontal, which is above the eyes and forehead bone. Maxillary, which is in the cheekbones under the eyes. Ethmoid, which is between the eyes and the nose. And sphenoid, which is in the center of the skull behind the nose and the eyes. Embryological development. Ethmoid and maxillary sinuses are present at birth. Frontal sinus develops during the 2nd year. Sphenoid sinus develops during the 3rd year. At birth, the ethmoid, sphenoid, and maxillary sinuses are tiny and cause problems in infants and toddlers. Frontal sinus develop between 4 to 7 years of age, causing problems in school-aged children and adolescents. Risk factors. We have nasal polyps, the elevated nasal septum, hypertrophy of the nasal turbinate, impaired ciliary function like in cystic fibrosis, foreign body lodged in nasal cavity, analgesic intolerance like NSAIDs, and pre-existing viral upper respiratory tract infections. On etiology, there are viral causes which are most common, like rhinovirus, coronavirus, influenza, and parainfluenza viruses. On bacterial causes, we have Strep pneumoniae, Haemophilus influenza, Staph aureus, and E. coli. On fungal, we have Aspergillus. Mode of transmission, through airdrops, particularly in winter. The pathophysiology. Sinusitis is triggered by 3 factors: mucosal edema, ciliary impairment, and altered mucus quantity and quality. This causes obstruction of sinus drainage pathways and results in stasis of secretion inside the sinuses, proliferation of various pathogens, and sinusitis. Recurrent, untreated or complicated acute sinusitis may lead to chronic sinusitis. On clinical features, acute rhinosinusitis. On unspecific symptoms, we have fever, which accounts for 50% of the cases, headache, general malaise, sneezing, nasal congestion, rhinorrhea, and postnasal drip. Hyposmia or anosmia, facial pain or pressure, and erythema. On specific symptoms, maxillary sinus manifests with pain in the jaw region which mimics dental pain. Frontal sinuses, pain in the lower forehead. Ethmoid sinuses, pain in the nasal bridge region or retroorbital pain. Sphenoid sinuses, pain located in the sphenoid bones near the optic nerve and pituitary gland. Chronic rhinosinusitis presents with facial pain, mucopurulent drainage on the anterior, posterior, or both sides, anosmia or hyposmia, nasal congestion, purulent mucus or edema in the medial meatus, polyps in the nasal cavity or medial meatus. On diagnosis, acute viral or bacterial rhinosinusitis is a clinical diagnosis. Imaging is only required for patients with any of the following: red flags for rhinosinusitis, like focal neurological deficit, severe headache, facial edema, and altered mental status. Risk factors for complications, e.g. immunosuppression, diabetes, and history of facial trauma, and recurrent acute rhinosinusitis. Chronic rhinosinusitis diagnosis is confirmed by CT scan with or without contrast, MRI with or without contrast, X-ray of the sinuses, which is no longer recommended due to limited sensitivity and specificity, direct visualization with nasal endoscopy, which is preferred, and anterior rhinoscopy. On treatment, uncomplicated viral rhinosinusitis is usually self-limiting. On symptomatic treatment, we do nasal saline irrigation, oral analgesics with ibuprofen or acetaminophen, intranasal steroid with mometasone, and decongestant with oxymetazoline. On antibiotic treatment, Observe for up to 7 days before initiating antibiotics. First-line antibiotic therapy with amoxicillin with clavulanate for a duration of 5 to 10 days in adults. On surgery, indications. If there is evidence of structural abnormalities like polyps, masses, or anatomical obstructions, treatment failure or complications of rhinosinusitis, and acute invasive fungal rhinosinusitis. Complications. On local spread, there is mucocele, osteomyelitis, especially of the frontal bone, also known as postpathic tumor. Spread to the orbit, there is preceptor or orbitocellulitis, orbit abscess, cavernous sinus thrombosis, and cavernous sinus syndrome. Intercranial spread, there is subdural abscess, which is most common, meningitis, and brain abscess. Thank you. Do not forget to like, comment, share, and subscribe. In the bio, you'll find the link to our Instagram, Facebook, and SlideShare account.